So good day, Bacharis. To continue with our discussion, previously we had our physical or gross examination of urine. Now we will proceed with chemical examination of urine. But before that, let us bow down our heads for a word of prayer. Our great God, loving Heavenly Father, Lord, we come before the throne of grace. I would like to ask for forgiveness for all the things that we've done against Thee, and ask for Thy guidance, your Lord, as um, we tackle on a different topic today. I pray that You'll pour us your knowledge, wisdom, and understanding, that we may be able to grasp the things that we need to learn, especially your students, dear Lord. Lord, we're nothing without You. Please be with us. In Christ's name we pray. Amen. Okay, now, chemical examination of urine. Okay, routine chemical examination of urine has changed dramatically since the early days of urine testing. Ano naman, due to the development of the reagent strip method for chemical analysis. Reagent strips currently provide a simple, rapid means for performing medically significant chemical analysis of urine, which includes pH, protein, glucose, ketones, blood, bilirubin, urobilinogen, nitrite, leukocytes, and specific gravity. Okay, so our reagent strips is our primary methodology for the chemical examination of urine. And there are two major reagent strips used, that is multi-sticks and chem strips. Okay, so how are we going to use our reagent strip? So saan man na nato paggamit? Of course, all of you are familiar with how to use the reagent strip, because I believe all of you have performed urinalysis. Okay, but before the ay na magtakol taon saon paggamit sa manual reagent strip, so unsa din ng reagent strip? Okay, reagent strips consist of a chemical impregnated absorbent pads attached to a plastic strip. Okay, a color-producing chemical reaction takes place when the absorbent pad comes in contact with urine. So, I believe pod nga kitang tanan nakagamit na taog reagent strip. Okay, yan sa siya. It is a plastic strip. And on that plastic strip kay na ay absorbent pads. And unsa may naa ng absorbent pads, it is impregnated with chemicals. And those chemicals mo react sa unsa man chemicals present in the urine. Okay? So unsa na may procedure anino atong paggamit sa manual reagent strip. So make sure that the patient sample is in room temp. Kaya diba, na may uban nga urine nga naka-refrigerate. Okay, refrigeration is one of ways nga ato i-preserve ang ato nga urine. But before we can use it for chemical testing using our reagent strip, we should make sure nga unsa man naa sa room temp ang ato ang sample. Why is that? Okay, specimens that have been refrigerated must be allowed to return to room temperature prior to reagent strip testing. Kaya naman, as the enzymatic reactions on the strips are temperature dependent. So, unsa ang mga enzymatic nga reaction nga naa sa ato ang reagent strip? They are temperature dependent. Okay, those enzymes are unsa man dependent sa temperature. Some enzymes may be inactivated if naka room temp. Okay? Diba? If you've noticed, if you can still remember, enzymes mostly kay unsa man siya optimal siya kung ang iyang activity is optimal if naa sa room temp or especially naa sa body temp. So kinahanglan nga ibalik siya sa room temp before ta maka-proceed with our reagent strip testing. Okay? And also, our sample should be uncentrifuged and well mixed. Uncentrifuged and well mixed. Kaya naman, anong dili man nato i-centrifuge? Okay, unya na ta mag-centrifuge if we are going to our microscopic examination already. But for our chemical examination of the urine, we should use an uncentrifuged, well mixed urine. Kaya nga naman, for example, your RBCs and WBCs, if i-centrifuge na nimo, of course, This will settle at the bottom of the tube. And if masettle sila sa bottom sa tube, they will not come in contact with our reagent strip, and therefore it could render a false negative result. So again, uncentrifuge, well-mixed urine ang ato nga gamiton and naa sa room temperature. So once we have secured this sample, pwede na nato nga sugdan ang ato nga chemical examination of the urine using our reagent strip. So once na ana ang sample, we dip it briefly and start the timing. Okay? Briefly lang. Nganong briefly raman? Nganong dili man taas, no? One dip and make sure nga tanan nga absorbent pads are unsa man come in contact with the urine. Okay? So, allowing the strip to remain in the urine for an extended period may cause leaching of reagents from the pads. So, kinahanglan briefly ra gyud. No, very quick. Dip it. Make sure nga tanan na absorbent pad kay na touch sa urine, and then remove it. How are we going to remove it? Okay? To remove excess urine remaining on the strip, kay unsa man ato siya ipaagi sa side sa ato nga tube. Inig-remove na to ato siyang paagion sa side sa ato ang tube. And then, we remove excess pagyod nga mga urine by blotting it on an absorbent pad. Pwede tissue or gauze. Why do we need to remove excess na urine by blotting? Because excess urine remaining on the strip after its removal from the specimen can produce a runover between chemicals on adjacent pads, producing distortion of the colors. And dili pwede nga ma-distort ang ato nga color since our reaction is, or the result of our reaction kay unsa man based on the color na ma-produce. So if ma-distort ang color, dili na reliable ang ato nga result. Okay? To ensure against runover, blotting the edge of the strip on absorbent paper and holding the strip horizontally while comparing it with the color chart is recommended. Okay, unsaon na to pag-blot? Dili intaw ng absorbent pad ang ato ang i-blot ha. Katong ipakilid ra nato, ato itaktak kamay sa absorbent pad and pakilid. Okay, atong ipahid sa absorbent pad nga like tissue or gauze. Okay? And then, unsaon daw ang paggunit sa ato ang reagent strip? Unsa na to pag-compare? We hold it horizontally. Okay? And make sure po there is a good lighting para mas ma-identify na to kung unsa jud ang color nga na-produce sa reaction. Okay? So, once that is ensured na okay na, then we can discard our strip into biohazard waste. So how do we store our reagent strips? So ato pod na responsibility na unsaon nato pag-store, dili lang kay unsaon paggamit, pero dili ta kabaw unsaon siya pag-store, unsaon siya paghipos, unsaon siya pag-handle, no? So it must be protected from deterioration caused by moisture, volatile chemicals, heat, and light. Reagent strips are packaged in opaque containers with a desiccant to protect them from light and moisture. Strips are removed just prior to testing and the bottle is tightly resealed immediately. So dili pwede nga hala naadi ay kanang padong na specimen for urinalysis, ako magpagawas ko daan og reagent strip be. No. Only remove the reagent strip from its container once mugamit na jud ka. Okay? Bottles should also not be opened in the presence of volatile fumes. Okay? Manufacturers recommend that reagent strips be stored at room temperature below 30 degrees Celsius. Unsa? Ang ato ang storage temperature for reagent strip, it must be below 30 degrees Celsius but never refrigerated. Take note, never refrigerated. So for the quality control also of our reagent strips, okay, reagent strips must be checked with both positive and negative controls. Okay? Kapila man ta mo Kanus aman ni nato gami buhaton ang QC sa atong reagent strips. Okay? A minimum of once every 24 hours. Okay? A minimum of once every 24 hours. Okay? Many laboratories perform this check at the beginning of each shift. Okay? Ingon man din minimum. So, pwede ka nga, pila man ka shift in 24 hours. There are 3 shifts. So, for example, AM, PM, ug night shift, mag-QC sila, no? At the beginning of each shift. Testing is also performed when a new bottle of reagent strip is opened. No, kung naay bag-o nga giablihan nga reagent strip, ikay natungnan nga bag-o nga reagent strip, ikaw pod ang mag-QC. I-QC sa nimo before gamiton. Also, questionable results are obtained, mag-perform pod ta og QC. Or there is concern about the integrity of the strips. So now, our first parameter is pH. So along with the lungs, the kidneys are the major regulators of the acid-base content in the body. They do this through the secretion of hydrogen in the form of ammonium ions, hydrogen phosphate, and weak organic acids, and by their absorption of bicarbonate from the filtrate in the convoluted tubules. Okay? So, a healthy individual usually produces a first morning specimen that is slightly acidic. Nganong slightly acidic man ang pH? Okay? pH of 5.0 to 6.0 kung first morning. That is due to acidic urine or first morning urine is due to the decreased respiratory ventilation. No? Nganong slightly acidic ato ang first morning specimen, that is due to decreased respiratory ventilation. And more alkaline atong urine kung gikan ta kaon. Okay, that is what we call the alkaline tide. Okay, so our urine pH varies from 4.6 to 8.0. Okay, 4.5 to 8.0 by Brunzel. Okay, so though there are ranges no 4.6 to 8.0 sa atong urine pH, there is no normal values assigned to urinary pH, and it must be considered in conjunction with other patient information such as the acid-base content of the blood, the patient's renal function, the presence of urinary tract infection, the patient's dietary intake, and the age of the specimen, as these things that I have mentioned will affect the pH of the patients. Imong tan-aw. So, kung example, naa siya urinary tract infection, what is the expected na pH result? Okay, mostly, if naa UTI, the pH will be alkaline. Okay? So, what is the clinical significance of pH? It aids in determining the existence of systemic acid-base disorders of metabolic or respiratory origin and in the management of urinary conditions. Okay? It is considered contaminated if the pH falls less than 4.0 and unpreserved if the pH kay mabot siya og 9.0. So, different causes of acid and alkaline urine. So, under the acid urine, unsa may different causes? Emphysema, diabetes mellitus, starvation, dehydration, diarrhea, infection with E. coli, high protein diet, medications such as methenamine mandolate, fosfomycin, tromethamine. And if pH is less than 4.5, considered contamination. Okay? In alkaline urine, also hyperventilation, vomiting, renal tubular acidosis. Now, take note of this, renal tubular acidosis. Miss, acidosis, pero nganong alkaline urine man? Okay, your renal tubular acidosis is the inability of your kidneys to produce acidic urine. Okay? Ang tubules ang acidic, no? Dili ang urine. Dili sila makaproduce og unsa man acidic urine. So therefore, ang pH ato ang urine is alkaline. So again, in our renal tubular acidosis, ma-remain or ma-accumulate ang acid in the body but not in the urine. Dili ma-excrete sa urine ang acid. Okay? So, and then also presence of urease producing bacteria such as your Proteus and vegetarian diet. So, in your vegetarian diet, maka-expect ka nga alkaline imong urine. Okay? So, with an exception of your cranberries. Okay? Cranberries, dili siya makaproduce og alkaline urine but rather an acidic urine. And your cranberries are used as medication kung naay infection. No, pero dili jud ingon nga mora na gamiton, but it is advised nga mo take og cranberry juice for those nga naay frequent urinary tract infections. Okay, vegetarian diet, that includes vegetables and also your fruits. Okay, alkaline urine, but again with the exception of cranberries. Your cranberries will produce an acidic urine. Mo na nga gamiton pod siya sa pag-treat or alongside with other medications sa inyong urinary tract infection. Okay, old specimens. If pH is more than 9.0, specimen is unpreserved. So we have two here, multi-sticks and chem strips. So for your reagents in multi-sticks, we use methyl red and bromthymol blue, and sensitivity is from pH 5 to 9. So our chem strip uses same methyl red and bromthymol blue but with an addition of phenolphthalein. Okay, sensitivity is also the same with your multi-sticks, pH 5 to 9. Okay, what is the principle of our pH in the reagent strip? Double indicator system. Anong double indicator system? Because we are using two indicators, methyl red and bromthymol blue. Okay, methyl red at pH range 4.4 to 6.2, mo change ang color from into red to yellow. Red to yellow. Kung ang urine pH gani sa tuang sample, mo fall under gani or the ranges 4.4 to 6.2, ang atong absorbent pad, ang color niya is red to yellow. Okay? Bromthymol blue at pH range 6 to 7.8, yellow to blue. Okay? Yellow to blue ang color if slightly alkaline na pod ang ato nga sample or alkaline na ato nga sample. And also natay nitrazine paper or litmus paper which measures pH only. So atong litmus paper, I believe nakagamit na pud mo og litmus paper, di ba? Naana ka ng blue o red na paper. Na if once i-dip nimo sa sample ang kanimong litmus paper nga color blue, mo remain gay siya nga blue, that is alkaline. But if mo turn pink gani na or red ang inyong blue nga litmus paper, meaning the sample is acidic. Okay? If ang red pod i-dip ninyo, mo remain siya red or pink, then that is acidic. But if mo turn into blue siya, that means basic. Pero dili ang kaninyong nitrazine paper or litmus paper will not tell you kung unsa nga pH range. Unlike your reagent strip, maingon na siya acidic or basic, pero wala siya nag-ingon sa ranges sa pH. Okay, what are other diagnostic methods? So aside from your reagent strip, we also have pH electrode. This pH electrode is used in patients with disturbance of acid-base balance. Okay? Unsa man yung pH electrode? pH meter with glass electrode. Again, unsa nga electrode? Glass electrode. Okay? Titratable acidity of urine measured by titrating an aliquot of unsa nga sample 24-hour urine with 0.1 N sodium hydroxide with pH 7.4 as its endpoint. Okay? Normal titratable acidity 200 to 500 ml 0.1 N sodium hydroxide or 20 to 40 milliequivalents of per 24-hour or 26 ml 0.1 N sodium hydroxide per kilogram body weight. So, nakatry naman mo og titration, no? So, it's not really used in the laboratory as ang process niya is tedious. Okay? titration. So kisa may naka-remember sa ilang titration, no, usahay maka wag pasensya ang pag-titrate o kay nalapas na. Okay, or nakalimot day kag butang sa indicator nganong man jud ni pink, kay nalimot day kag butang sa indicator or chromogen. Okay, unsa nga sample gamiton? 24-hour urine. Okay, now our next parameter, we have protein. So of the routine chemical tests performed on urine, the most indicative of renal disease is the protein determination. Proteinuria is often associated with early renal disease, making the urinary protein test as an important part of any physical examination. So unsa daw ang ato ang protein? It is the most indicative of renal disease. Okay? Unsa nga test? It's our protein determination. So, if naay protein sa ato ang urine, no, in large amounts, it could mean that we have renal disease. Okay? Normal urine excretion of protein is less than 10 mg per dl or 100 mg per 24 hours. But as for Henry's, it could reach up to 150 mg per day. So, quantification of proteinuria, makaingon ta, there is heavy proteinuria when we excrete more than 4 grams of protein per day. Okay? Moderate proteinuria, 1 to 4 grams per day, and minimal proteinuria kung less than 1 gram per day. So, consists primarily of low molecular weight proteins. Okay? So, albumin, it is the major serum protein found in normal urine. Okay, due to its low molecular weight, albumin is the major serum protein found in normal urine. Nganong siya gani ang major serum protein nga makit-an sa urine? Because of its low molecular weight. Other proteins that we can see in the urine is serum and tubular macroglobulins. We also have Tam Horsfall protein, or recently called as uromodulin. Your Tam Horsfall protein, dili ni siya gikan sa inyo nga plasma nga protein ha. Your Tam Horsfall protein or your uromodulin, asa man na siya? It is produced by the renal tubular epithelial cells. Okay? It is produced by the renal tubular epithelial cells. Uromodulin is routinely produced in the distal convoluted tubule. Okay? DCT. Again, your Tam Horsfall protein is not produced in the plasma or does not come from your plasma, but is rather originates in the kidney, produced in the kidneys. Okay? We also have proteins from prostatic, seminal, and vaginal secretion. So, clinical significance or causes of pre-renal proteinuria. Okay, so when we say pre-renal proteinuria, no, it is caused by conditions affecting the plasma prior to reaching the kidney. Prior. So, meaning dinhi, ang hinungdan nga nung naatay proteinuria is not because that there is something wrong with our kidneys, but rather, unsa man, it is an overflow kung unsa daghan ra kaayo siya sa ato nga plasma. So, this condition is frequently transient, no? So, dili na siya permanent, no? Dili always nga naa kay proteinuria. Transient ra siya. This is caused by increased levels of low molecular weight plasma proteins such as hemoglobin, myoglobin, and acute phase reactants. Okay? The increased filtration of these proteins exceeds the normal reabsorptive capacity of the renal tubules, resulting in an overflow of the proteins into the urines. In the urine. Yan na S. In the urine. So, overflow lang ni siya. Since, dili na ma-reabsorb tanan siya sa, nilapas na siya sa reabsorptive capacity of our tubules, then makita na nato siya sa ato ang urine. Okay, again, there is no problem with our kidneys. It's just that, ini-increase lang ni sila sa ilaha nga level in the plasma. Mo na nga dili na makayag reabsorb sa tong tubules, mo na nga makita na siya or ma-excrete na siya sa urine. Okay? So, mga low molecular weight protein. So, hemoglobin, this is associated or makita ni nato sa tong urine if in excess na siya due to intravascular hemolysis. And myoglobin pod if there is muscle injury. And acute phase reactants if there is infection and inflammation. So, pwede pod ni si Benz-Jones protein. Okay? Pwede ni siya ma-detect using our reagent strip. No? This is seen in patients with multiple myeloma. So, unsa man ang multiple myeloma? A proliferative disorder of the immunoglobulin producing plasma cells. The serum contains markedly elevated levels of monoclonal immunoglobulin light chains. That is our Benz-Jones protein. So, next we have renal proteinuria. Results to increased excretion of albumin associated with true renal disease. Now, with our renal proteinuria, true renal disease na siya. Kung ato ang pre-renal, dili or walay problema ato ang kidneys, kani si renal proteinuria, as its name suggests, nga there is a problem with our kidneys, mo na nga makakita ta og protein sa ato ang urine. Okay? We have glomerular proteinuria, okay, or glomerular disorders. These usually produce heavy proteinuria. Okay? When the glomerular membrane is damaged, selective filtration is impaired and increased amounts of serum protein and eventually red and white blood cells pass through the membrane and are excreted in the urine. Okay, so conditions that present the glomerular membrane with abnormal substances such as amyloid material from amyloidosis, toxic substances, and immune complexes found in SLE and streptococcal glomerulonephritis are the major cause of proteinuria due to glomerular damage. Okay? So, glomerular disorders will be discussed differently sa next na mga topics. We'll dig deeper into that. But for now, agian na to siya. Also, increased pressure from blood entering the glomerulus may override the selective filtration of the glomerulus, causing increased albumin to enter the filtrate. But this condition may be reversible, such as occurs during strenuous exercise, dehydration, or naay hypertension. Okay? Naapod tayo proteinuria if ever there is diabetic nephropathy. Kana ganing uncontrolled diabetes na. Okay? So that is why it is important nga unsa man makontrol ang diabetes. Kay mo start na gani na og show og unsa man proteins in the urine nya naa kay diabetes mellitus, then that may indicate nga naguba na or affected na ang imuhang kidneys by your diabetes. So, renal proteinuria still under tubular damage. So, ang tubules pod ang na-damage. Ganin na kay ang glomerulus man to or ang ato ang filter, ato ang salaan. Now, our tubular damage. Okay? This is due to toxic substances, viral infections, and heavy metals. Okay, Fanconi syndrome. Fanconi syndrome is different from your Fanconi's anemia. So, kaninyong Fanconi syndrome kay it is the inability of your tubules to reabsorb substances. So, tanan na moagi niya ilabay niya. So, tanan makita sa urine. So, dili na sa inyong Fanconi syndrome, ilabay tanan niya. Dili siya mag-reabsorb. Okay, we also have orthostatic or postural proteinuria. This is makita ni siya usually sa mga young adults. Nganong gitawag man siya postural proteinuria? Tungod rin sa imuha posture mo na nagka-proteinuria ka. No, so unsaman ni nato pag-test kung tinuod ba jud ni nga nay proteinuria or orthostatic or postural proteinuria ra ni siya. Okay, so unsa na nato pag-compare? So, ang patient, no, mag-submit siya og first morning urine nga specimen. Okay? And after 2 hours or long period of time nga pabarugon siya, magkuha na pod og sample. If true gani na nga proteinuria or clinical gani nga proteinuria, ang iyang first morning is positive sa protein. Also with the sample nga katong after standing for long period of time. Okay? So kung mingon ta nga tinuod na or clinical na nga proteinuria, both the first morning specimen and the specimen after standing for long period of time is positive. Okay? Pero kung orthostatic or postural proteinuria rin na siya, the first morning specimen is negative sa protein, but the sample after after period of time nga nakabarog ra ang inyuhang patient is positive. Okay? Again, kung postural proteinuria ang first morning is negative, and then the sample taken after standing for long period of time is positive. Okay mo na ang orthostatic or postural proteinuria. Okay? Postrenal proteinuria, protein is added to the urine as it passes through the structures of the lower urinary tract. So makita ni siya in lower urinary tract infections, prostatic fluid or spermatozoa, injury or trauma, and vaginal secretion. So, microalbuminuria, it is the presence of albumin in urine above the normal level but below the detectable range of conventional dipstick methods. And it is also an indicator of early glomerular damage. Okay? So, principal proteins in glomerular proteinuria, we have albumin, transferrin, alpha-1 antitrypsin, and alpha-1 acid glycoprotein. Principal proteins in tubular proteinuria, we have albumin, beta-2 macroglobulin, retinol binding protein, alpha-1 microglobulin, and alpha-2 microglobulin. So, diagnostic methods, we have reagent strip method, and the principle is protein error of indicators. Nganong gitawag man siya og protein error of indicator. Okay, also pwede siya tago na Sorensen's error of indicators. So, again, nganong gitawag siya protein error of indicators. Okay, it is because contrary to the general belief that indicators produce specific colors in response to particular pH levels, certain indicators change color in the presence of protein even though the pH of the medium remains constant. This is because protein, primarily albumin, accepts hydrogen ions from the indicator. So, dili pH dependent ang reaction diri, no? With compared with other nga reactions nga, ang ilahang color change is due to the change in pH, no? So, at the pH level of 3, both indicators appear yellow in the absence of protein. Okay, ang basihan diri ang presence of protein, not the pH. Mo nang gitawag siya protein error of indicators. Okay, so however, as the protein concentration increases, the color progresses through various shades of green and finally to blue. So again, indicator plus protein, kung naa na ang protein, dinha pa siya mo change sa color. But, ang indicator, if wala pa ang protein, yellow ra gyud na siya. Indicator is color yellow. Unya na pag madugangan og protein or naa ang protein nga mo change siya ang color. Dili siya dependent sa pH unlike other reactions. Okay, mo nang gitawag siya protein error of indicators. So nata dinhi multi-sticks and chemstrip na pod ang ato ang i-compare. Okay, sensitivity 15 to 30 mg per dl albumin. Okay? Si chemstrip kay mas gamay iya ha. 6 milligram per DL albumin. So, mas sensitive si chemstrip. Kay gamay lang ang iyahang or mas gamay nga presence sa inyong albumin, iyahan na nga ma-detect. Compared with your multisticks nga 15 to 30. Okay, reagents, tetrabromophenyl blue. Basta gani tetrabrom, that is your protein. Okay? Sa inyuhang chemstrip, tetra gihapon and daghan nga number. Tetrachlorophenol 3, 4, 5, 6, tetrabrom sulfophthalate. Okay? So, tetrabrom, that is reagent for your protein. Okay, sources of error, false positive, highly buffered alkaline urine. Okay, highly buffered alkaline urine. You also have antiseptics, chlorhexidine, pigmented specimens. As you can remember, phenazopyridine sa ato ang previous nga topic, 'di ba? Ma-produce siya og orange nga color sa urine, and this will interfere with the color reaction, no? So color reaction mo ng highly pigmented specimens may affect the result of our reaction. Okay, also have quaternary ammonium compounds such as detergent. You also have loss of buffer from prolonged exposure of the reagent strip to the specimen. As for the false negative, proteins other than albumin. So, false neg. So, naay present sa protein, but because it's not albumin nga protein ang naa sa inyong urine, dili gid siya ma-detect because your reagent strip test for protein is only sensitive to your albumin and specific to your albumin. So, other diagnostic methods, we have SSA or sulfosalicylic acid precipitation test. This is same with heat and acid precipitation test or nitric acid test. So, kanilang si sulfosalicylic acid test, wala na siya nag-need og heat. Okay, cold precipitation test ninyuhang SSA. So, no heat needed. Okay, principal precipitation test, sensitivity, detect 5 to 10 milligrams of protein. So, unsa nga mga proteins iyang ma-detect? We have albumin, globulin, glycoproteins, and Benz-Jones proteins. So, kung ato ang reagent strip is specific and sensitive to albumin, ang ato ang sulfosalicylic acid precipitation test kay makadetect siya not just your albumin but also globulins, glycoproteins, and Benz-Jones proteins. Asa ganin ni associated atong Benz-Jones proteins? It is associated with multiple myeloma. So procedure, add 3 ml of 3% sulfosalicylic acid reagent to 3 ml of centrifuge urine and then mix by inversion and observe for cloudiness. So if mag-cloudy na ganin na, meaning there is precipitation, meaning there is the presence of protein in the urine. Okay? So grading sa ato ang SSA test. K grade, turbidity, and protein range. Negative when there is no increase in turbidity. So ang range na less than 6 mg per DL lang. Kaya nga balik ta siyang sensitivity, 5 to 10. Okay? If less than 6 milligrams per DL, negative. Trace noticeable turbidity, 6 to 30 milligram per DL of protein. 1 plus distinct turbidity with no granulation, 30 to 100 milligram per DL ang protein range. So, kani, ako ni siya ma-remember kaning 1, 2, 3, and 4. Kani 1, 2, and 3, and 4 sa iyaha nga gi-describe, diba? Ang 1 plus turbidity lang. Distinct turbidity with no granulation. 1 lang, turbidity. Sa 2 plus na ganit, turbidity with granulation na. Okay? Duha na. Okay? Turbidity with granulation. Sa 3 plus, turbidity, granulation with flocculation. Okay, again, marag na-distort ang ako ang pipitino. So, balik. Sa inyuhang 2 plus, turbidity with granulation with no flocculation. Ang inyuhang 3 plus, tulo na kabuok, turbidity with granulation and flocculation. Okay? Sa inyong 4 plus, clumps of protein na. Okay, so 1, 2, 3. 1, turbidity lang, no granulation, and protein range 30 to 100 milligram per DL. 2 plus, turbidity with granulation but with no flocculation. Range is 100 to 200 milligrams per DL. 3 plus, turbidity with granulation and also flocculation. Our protein range 200 to 400 milligrams per DL. And 4 plus na, clumps of protein na siya, meaning more than 400 milligram of DL, 400 milligram per DL of protein na ang present sa urine. Okay, sources of error for SSA. Okay, phosphates and urates may confuse interpretation. Nga naman, 'di ba? Ang ato ang positive nga reaction ani is precipitation or turbidity. So if there is phosphates or urates nga sediments present in our urine, pwede na to ma-confuse. Boy, ngano naman ni murag mo ni maka-cause og turbidity. Dili dayto ang protein, nara day phosphates and urates. We also have drug metabolites to butamide, sulfonamide, high-dose penicillin, cephalotin, and chlorpromazine. Okay? Also abundant red blood cells or white blood cells. Kay again, if dili pud clear nga to nga specimen daan na nagani na mga red blood cells dinha, mura siya og naay precipitate or na siya turbidity. Okay? False negative and highly buffered alkaline urine. Okay? Quantitative protein determination, adaptation of the precipitation and or colorimetric method. So under quantitative protein determination, we have precipitants, sulfosalicylic acid. This is poor precision. Okay? Trichloroacetic acid, ang inyong dapat i-remember sa inyong TCA or trichloroacetic acid that it is or it uses Biuret reaction. Okay, Biuret reaction. Your Biuret reaction will be explained further sa inyong clinical chemistry when you tackle about proteins. Okay, resultant precipitate may be measured by photometer or nephelometer. Okay, photometer or nephelometer. So for your colorimetric, okay, Comasi Blue method, Poncho S method, benzethonium chloride turbidity method, and pyrogalol red molybdate. Okay, so this mga method will not, dili na ko siya i-discuss gid in detail because it will be discussed in your clinical chemistry. So kani nga mga test kay dili kay siya relevant, kay di kay siya ginagamit sa laboratory nga under sa clinical microscopy nga section. So mostly ra jud sa inyong laboratory reagent strip gid na. Okay? But include lang ni nato siya dinhi, agian lang nato, but a more detailed discussion will be on sa inyong clinical chemistry. Okay? So microalbuminuria determination methods usually detect small amounts of albumin and beta-2 macroglobulinemia. So, unsa man ang mga methods? So, immunologic method uses antibodies against the protein. For example, we have Micral test. Okay? It is a semi-quantitative method. Okay? And oxytetracycline may interfere. So, principal enzyme immunoassay sensitivity 0 to 10 mg per DL albumin. Reagents, gold-labeled antibody galactosidase, chlorophenol, and galactosidase. Interference, false negative, and dilute urine. We also have Clinitec microalbumin, highly sensitive dye binding method. Advantage with additional pad for simultaneous measurement of creatinine. Disadvantage, not specific for albumin, and dye can bind to Tam horsefall mucoprotein. Okay, so remember the disadvantage sa inyong Clinitec microalbumin, it is not specific for albumin. Pwede nga mo bind ang dye sa inyong uromodulin or Tam horsefall mucoprotein. Okay, sa inyong immunodip, principal immunochromatography. So, mura nagkana inyong pregnancy test kit. So, ang iyahang result kay na ay lines. Okay, lines. Okay, sa inyong immunodip na asiyay Ang inyong strip kay naka-pack individually in specially designed containers. Okay? The container is placed in the urine specimen for 3 minutes. A controlled amount of urine enters the container through a vent hole. Okay? The urine encounters blue latex particles coated with anti-human albumin antibody. Okay? So, albumin in the urine binds with the coated particles. The bound and unbound particles continue to migrate up to the strip. The migration is controlled by the size of the particles. Unbound particles do not migrate as far as the bound particles. So, mingon ganita og bound particles, meaning mauni ang naay nakabind nga albumin sa atoang antibody nga present sa atoang kit. Okay? Nya, asa daw mas mo migrate further ang katong bound compare sa unbound. Okay? First, a blue band is formed by the unbound particles. The bound particles continue to migrate and form a second blue band further up the strip. Okay, the top band therefore represents the bound particles. So, naay duha ka band na ay bottom, na ay top. Ang katong si bottom nga line, okay, or band, nagrepresent to siya sa unbound. Ang katong top, since mo migrate further ang inyuhang unbound, mao to siya ang nagrepresent sa, ang katong top, kay mo to siya ang top nga band kay nagrepresent sa bound. Since your bound nga particle, mas mo travel siya further than your unbound. Okay? The color intensity of the band is compared against the manufacturer's color chart. A darker bottom band represents less than 1.2 mg per dl. Okay? Ang darker bottom ko no, meaning mas daghan ang unbound. Okay? Unbound. So, meaning gamay ra ang protein nga present. Okay? Muna nga, less than 1.2 mg per dl ra. Equal band colors represents 1.2 to 1.8 mg per dl. And a darker top band represents 2 to 8 mg per dl of albumin. A darker bottom band is negative, equal band color is borderline, and a darker top band represents positive result. Ngano gani ang top band kay mag-represent siya positive results because ang naa sa top band are those that are bound. Meaning bound na ay albumin naka-attach. Meaning daghan albumin ang naka-attach sa ato ang antibodies. Okay, that is our immunodip. Okay, another we have nephelometric method. We also have radioimmunoassay. And next is Benz-Jones protein determination. So, unsa man ning Benz-Jones protein determination? 'Di ba nag-mention na ta ganina ang kaning Benz-Jones protein. Associated with multiple myeloma. Okay, unsa na to siya pag-detect or pag-diagnose, okay? Using heat and acetic acid test. Benz-Jones proteins is special siya nga protein. Kaya nga naman, unsa may distinctive characteristics in yung Benz-Jones protein. Your Benz-Jones proteins precipitate at temperatures between 40 to 60 degrees Celsius. Sa kana nga temperature mo precipitate siya, but it will redissolve at 100 degrees Celsius. Okay? Precipitation in the cold with salts, ammonium sulfate, and acid. So, ang inyuhang Benz-Jones, remember nga mo precipitate siya between 40 to 60 degrees Celsius, but mo redissolve siya at 100 degrees Celsius. Okay? So, also have toluene sulfonic acid test, SSA test, or Exton test. Okay, mga tana gani, unsa na nga reagent, para asa na ang Exton reagent. Okay, pwede po na siya nga si SSA. Other name ni SSA is Exton test. Okay, pangutanon gyud mag Exton reagent, that is SSA. If na ay SSA sa choices. Hindi mo kita, hala, unsa para asa ni exton reagent niya, wala mo kakitag exton test. Okay, that is your SSA, sulfosalicylic acid test. Okay? Result niya, precipitation. You also have Osgood-Haskin. Positive result is precipitation. Okay, other test, you have Bradshaw, HCl, also precipitation. Napuyputnam et al. 2M acetate buffer precipitation. Jacobson-Milner, concentrated, again, for your Jacobson-Milner, concentrated nitric acid, and 25% acetic acid. Precipitation gihapon ang result. Now, we have electrophoresis. So, your electrophoresis is the best method for detection of your Benz-Jones proteins. It could be presence of either kappa or lambda light chains. Okay, methods: amido black stain or Comasi brilliant blue stain. Okay, sa inyo electrophoresis, 'di ba, after ana, kadi ba tong nain na mga lines, and unsaon man na siya unsa man na pagbasa ninyo sa lines, okay, it will be stained or naa mag-add ta og dye, and the intensity of the dye is measured by, okay, so ang pag-measure na to na, di ba, natay amido black stain and Comasi brilliant blue stain. So to quantitate that one, we use densitometry. Okay, densitometry. So naagian po na ninyo sa inyong mall bio kay daghan kay electrophoresis dito. Okay, other tests for albumin, you have SBAX test or Tsuchias modification. We use picric acid and ascorbic acid. We also have Shevke and Stafford's. We also have Kingsbury test, Kingsbury, Clark, and Purdy's. Okay, let's continue with glucose. So because of its value in the detection of monitoring of diabetes mellitus, the glucose is the most frequently performed chemical analysis on urine. Okay, pangutanon gani mo, what is the most frequently performed chemical analysis on urine? Your answer should be glucose. Okay? Okay, early diagnosis of diabetes mellitus through blood and urine glucose test provides a greatly improved prognosis. Okay? So helpful ang ato nga pag-detect sa glucose na agi sa urine or sa ato nga blood. For in this case, so urine. Okay, renal threshold for glucose is 160 to 180 mg per DL. When we say renal threshold, so katula na ma-reabsorb sa ato nga body. Okay, or ma-reabsorb sa ato nga kidneys. Magmalapas na gay 160 to 180 mg per DL ang present nga glucose, well then, makita na nato siya sa urine. Okay? Under normal circumstances, almost all the glucose filtered by the glomerulus is actively reabsorbed in the PCT. Unsa? Actively. There is active transport or active nga reabsorption in the PCT. Therefore, urine contains only minute amounts of glucose since ma-reabsorb man siya. Tubular reabsorption of glucose is by active transport in response to the body's need to maintain an adequate concentration of glucose. Pero kung musubra na gani kataas ang glucose, unsa man, same as occurs in diabetes mellitus, the tubular transport of glucose has reached its renal threshold and glucose appears in the urine. Muna to kung gingon nga pag malapas na ning 160 to 180 mg of per DL of glucose, makita na siya sa urine. Okay? Glucosuria with hyperglycemia. Mingantag hyperglycemia na ay glucose in the urine because of increased amount of glucose in the blood. Okay? Generally due to overflow disorders. Overflow, daghan ra kayo siya sa body, need na i-excrete. Okay mo na overflow disorders. Okay? kung unsa lang ang ginid sa atong body, mo lang na ang reabsorb sa ato nga kidneys. But if there is an increased amount of it or excess of it, then we have to remove it from the body. Okay? So, glucosuria with hyperglycemia, diabetes mellitus. Okay? We also have alimentary glucosuria. Okay? Ang inyong alimentary glucosuria or hyperglycemia is transient. Kaya naman, this is only affected by the carbohydrate intake of a person. Wala siya diabetes mellitus. Wala pa siya nagka-diabetes mellitus pero naa lang siya hyperglycemia kay tungod sa iyahang gipang kaon or iyahang gipang inom. Okay? Alimentary glucosuria or glycosuria. Okay? Ni-increase ang glucose concentration in the body because of the intake. Okay? Increase intracranial pressure in tumors, intracerebral hemorrhage, and skull fractures. Okay, certain endocrine diseases or hormone-producing tumors such as Cushing's or pheochromocytoma. So, Cushing's, so ma-discuss pod ni in detail also in clinical chemistry. So, Cushing's, kani mga hormone deficiency or increase na mga hormones kay makaproduce pod og hyperglycemia. So there are certain hormones because the only hormone that can lower blood sugar is insulin. Other hormones kay hyperglycemic sila. Okay? So glucosuria with hyperglycemia continuation, we have hyperthyroidism. Okay, also in occasionally and transiently after myocardial infarction, after certain types of anesthesia such as ether and drugs, thiazides, corticosteroids, and adrenocorticotropic hormones, and pancreatic tumor and diseases. So, glucosuria without hyperglycemia. Now, you can think of it, nga naman nga naatay glucose in the urine, pero dili man increase sa ato nga blood. This generally results from accumulation of the renal type caused by malfunctions in the tubular reabsorption mechanism. So, ang problema, dili na kay tungod increased ang amount or concentration in the body or in the blood, but rather there is a problem really in our kidneys. Nga naman wala siya na reabsorb. Na supposedly, our glucose must be reabsorbed back sa ato ang body kay kinahanglan man nato ang glucose. We need to consume glucose to produce energy. But here, wala siya na reabsorb by the tubules. Okay, so meaning, walay overflow, but naabot siya sa kidneys or sa ato ang urine, I mean, because there is problem with our kidney. Okay? Our tubules were not able to reabsorb the glucose. So, muna siya, renal glucosuria. You also have pregnancy, certain errors of metabolism such as Fanconi syndrome, as I've also mentioned sa previous na slides, no? Katong Fanconi syndrome, dili gyud maka-reabsorb ang ato ang tubules. So, ipanglabay gyud niya tanan. That includes our glucose. Okay, or after nephrotoxic, carbon monoxide, lead, and mercuric chloride. Next. Okay, diagnostic methods. We have glucose oxidase method. Okay, test is based on specific glucose oxidase and peroxidase method. A double sequential enzyme reaction. Nganong gitawag man nig double sequential enzyme reaction ang iyahang principle? Because we are using two enzymes for this reaction to happen or to occur. Okay? Glucose plus air in the presence of your glucose oxidase will be able to produce gluconic acid plus hydrogen peroxide. Okay? Glucose in the presence of air and also with the enzyme glucose oxidase, which is specific for your glucose, will produce gluconic acid and hydrogen peroxide. Okay, and that hydrogen peroxide produced in this first reaction will be the one to be used in your second reaction. Now, you have your hydrogen peroxide and then the chromogen, okay, chromogen, and also in the presence of the enzyme peroxidase will produce a will produce an oxidized chromogen. So there is color change plus water. Okay? So unsa na mga enzyme ang gigamit diri? On our first reaction, we use glucose oxidase. In our second reaction, we use peroxidase. And unsay result? Color change. Okay? Oxidized chromogen. Color change. Okay. So, clinic test out. Clinist text. So, ihang chromogen is ortho-toluidine. Color change, pink to purple, detects 100 milligram per dl of glucose. This is more sensitive to interfering substance such as ascorbic acid. Okay, we also have multisticks. Potassium iodine ang iyahang chromogen. Blue to brown at 30 seconds. Okay, blue to brown at 30 seconds. Your chem strip, ang iyahang chromogen is aminopropylcarbazole. Aminopropylcarbazole. Blue to brown gihapon siya, but at 60 seconds. You also have chem strip UGC, tetramethylbenzidine. Reagent pads have different sensitivities to urine glucose ranging from 60 mg per dl to 5 grams per dl. The strips are read at 2 to 3 minutes. So wala kaayon ni siya. No? So siya ang pinakadugay basahon if ever. 2 to 3 minutes. Okay? What is the advantage of your glucose oxidase method? It is specific for glucose. So, it does not react with lactose, galactose, fructose, or reducing metabolites of drugs. Okay, your glucose oxidase is specific to glucose only. Okay, sources of error, false positive, strongly oxidizing cleaning agents in the container. So, such as hydrogen peroxide and hypochlorites. False negatives, use of sodium fluoride as preservative. So, muna, diba, there is no really perfect nga preservative, no? I believe nagianan na ninyo with Miss Lily ang katong preservation of urine. So, different nga way of preserving your urine. So, wala dyan ingon nga perfect nga mo match sa tanan nga preservation sa urine. Okay? So, kung unsa lang ang best nga preservation method. Okay? For example, ani, magbutang kag sodium fluoride, false negative. Kaya nga naman, unsa gani na ang fluoride, sodium fluoride. Okay, your sodium fluoride, okay, it preserves the glucose. So, false negative. Okay, the diagnostic methods, we have copper reduction test. Okay, clinic test reagent strip based on the qualitative Benedict's test that contained copper sulfate. Okay, sodium carbonate and sodium citrate buffer. Okay, sensitivity minimum level of 200 milligrams per dl. So, kani si clinic test, marapod na ninyo Benedict's test. Pero, diri, diba, sa inyong Benedict's test, kay inyo pang i-hit ang inyuhang solution. But here, dili na mo kinahanglan mag-hit. Naara na siya ay adili day ni mao. Ang reagent strip pa day ni. Okay, ang kato datong tablet nga clinic test. Sorry about that. Okay, so, false positive, non-glucose reducing sugars. Okay? So, false positive, kadili ran ni siya specific sa inyuhang glucose. It could also detect reducing sugars such as your galactose, lactose, fructose, maltose, and pentose. Strong reducing substances, ascorbic acid and gentisic acid or homogentisic acid. Okay? Drugs give false positive results or unusual colors with clinic tests, especially cephalosporins and radiographic media. Tara, copper reduction tablet test detects 150 to 250 milligram glucose per deciliter of urine. Na siya copper sulfate, sodium hydroxide, sodium carbonate, and citric acid are incorporated into the tablet. So, mo ni si tablet, dili na siya need og hit because of sodium hydroxide. Si sodium hydroxide na ang mo produce og heat. So dili na ta kinahanglan nga mag Bunsen burner or mag alcohol lamp kay naa na siya sodium hydroxide. So no need for heating. Okay? So mo na kinahanglan pod nga inigunit ninyo or ang ato ang nga tube is thick-walled para dili mabuak tungod sa heat and also dili pod mapaso ang nagperform. Okay? Pass-through phenomenon occurs at very high glucose levels. Color produced passes through the orange stage and returns to a blue or green color. Final color doesn't compare with the section of the color chart. However, it corresponds most closely to significantly lower results. So, pass-through phenomenon. So, 5-drop method. Place 5 drops of urine in a dry test tube and add 10 drops of water. Add 1 Clinitest tablet and watch while boiling takes place. Wait for 15 minutes after boiling stops and gently shake and immediately compare color change to the color scale. Results correspond to the following approximately concentrations. Negative kung 0.25 gram per dl, 0.5 gram per dl, 0.75 gram per dl. Negative, and then 0.25, and then 0.5, 0.75, 1, and then 2 gram per dl. Okay, ang pass-through. So, ganitong pass-through, tungod sa ka-increase sa glucose, nilahot siya red and then ibalik sa blue. Okay, pass-through, it indicates that more than 2 grams per dl sugar is present. And this should be reported as more than 2 grams per dl. Okay, naapoy 2-drop method. Report results as 1 gram per dl, 2 gram per dl, 3 gram per dl, and 5 gram per dl. And more than 5 gram per dl if pass-through reaction occurs. Okay? So, kung sa 5-drop method gani, i-report na nimo siya ang pass-through phenomenon as more than 2 grams per dl. If nagay pass-through phenomenon, more than 2 grams per dl. Sa 2-drop method, mag 5 gram per deciliter ka if na ay pass-through reaction nga ma-happen. Okay? Summary of glucose oxidase and Clinitest reaction. Glucose oxidase positive. Clinitest positive. Glucose present. Nga na makaingon man ka nga glucose ang present nga naa din ha. It's because si glucose oxidase positive. Okay? Mingon kay ka glucose oxidase positive, again, our glucose oxidase is specific only to your glucose. Okay? So, ang nagpa-positive pod aning sa Clinitest, okay. Ang nagpa-positive aning Clinitest pod is glucose. Dili atong other reducing sugars. Okay? 1 plus positive ang glucose oxidase and negative ang Clinitest. Small amount of glucose present. Okay, small amount of glucose present lang. Muna nga negative si Clinitest. 4 plus positive, then Clinitest negative. Possible oxidizing agent interferes. Okay, kani glucose oxidase is negative, Clinitest is positive. Possible oxidizing agent interference. I think this is wrong. Ang kaning sa last nga interpretation. So, kaning negative gani ang glucose oxidase, tapos positive sa Clinitest. Okay, please disregard ang kaning dinhi sa interpretation sa last nga table. Negative glucose oxidase pero positive siya sa imuhang Clinitest, meaning dili wala siya glucose, but there is a presence of other reducing sugars in the urine. Okay, glucose oxidase nga negative kay dili man glucose ang naa. Ni positive siya sa Clinitest kay there is a presence of reducing sugar other than your glucose. Okay? Other tests for urine glucose, we have Felling's test. Reagent A, cupric sulfate, distilled water. Reagent B, Rochelle salt. Unsa man ang Rochelle salt? We have sodium potassium tartrate, potassium hydroxide, and distilled water. Okay? Yellow precipitate ang iyahang positive reaction. We also have phenylhydrazine or ozone test. Reagent is phenylhydrazine, hydrochloride, and sodium acetate. Positive is crystal formation or phenylglucosazone. Okay, Nylander's test reagent, potassium hydroxide or sodium hydroxide copper sulfate, yellow precipitate. Moore and Heller's reagent is potassium hydroxide. Okay, so dili ka na siya ginagamit sa lab kanisiya. More on kani mga diagnostic na methods kay na ma-discuss pa ni deeper in your clinical chemistry. Okay, other sugars in urine aside from your glucose, we have galactose. Okay, disorder deficiency of galactose 1 phosphate uridyl transferase or galactokinase. Okay, makita ni siya sa mga babies, failure to thrive, no? Glucose oxidase and copper reduction test as your screening test. Confirmatory test, thin layer chromatography in urine and erythrocyte enzyme assay. Lactose, normal pregnancy or during lactation, deficient enzyme lactase. Lactose test, add 3 gram lead acetate to 15 ml urine, shake and filter. Boil nimo ang filtrate, add 2 ml concentrated add 2 ml concentrated ammonium hydroxide and then boil. Lactose, if nagani lactose, brick red solution, red precipitate with clear supernatant. Okay, if there's a presence of lactose, brick red solution, red precipitate with clear supernatant. Okay, pag glucose ang present, yellow solution and precipitate. Okay, confirmatory test, thin layer chromatography. Okay, also have fructose, parenteral feedings, enzyme deficiency, mga disorder. Okay, screening test, you have glucose oxidase and copper reduction test and resorcinol test. Okay, resorcinol test. Fructose gani, resorcinol test. Confirmatory test, same with other sugars, thin layer chromatography. Pentose, large amount of fruit excretion, a large amount of fruit, gigikan na siya sa fruit, excretion of L-xylose and L-arabinose in amounts up to 0.1 gram per day. Okay, screening test, L-cellulose at concentration of 250 to 300 grams reduces Benedict's reagent at 50 degrees Celsius within 10 minutes or at room temperature for several hours. Okay, thin layer chromatography still. Sucrose disorder, sucrase deficiency, adextrinase, isomaltase. Okay, for the screening test, glucose oxidase and copper reduction test. Okay, thin layer chromatography. Okay, clinical significance of your ketones. So, ketones sa data. Okay, ketones. Okay, next is ketones. So, before the clinical significance, ato sa ng ketones. The term ketones represents 3 intermediate products of fat metabolism, namely acetone, which is 2%, acetoacetic acid, 20%, and beta-hydroxybutyrate, 78%. Normally measurable amounts of ketones do not appear in the urine because all metabolized fat is completely broken down into carbon dioxide and water. However, when the use of available carbohydrates as major source of energy becomes compromised, body stores of fat must be metabolized to supply energy. Ketones are then detected in urine. So, sa normal nga condition, dili ka kakitag ketones in your urine. So, product siya of fat metabolism. So, if na question nga, unsa nga problem sa metabolism ang if naapoy ketones, the presence of ketones. So, dili ka moingon nga fat metabolism, but a problem in carbohydrate metabolism. Okay? There is a problem with your carbohydrate metabolism mo na nga instead nga ang carbohydrate ang imuhang gina-consume, ang imuha na nga fats. Okay? No, na makaproduce na og kaning ketones. Okay? Clinical reasons, clinical significance. Reasons for increased fat metabolism include the inability to metabolize carbohydrate. Muna akong ingon. inability to metabolize carbohydrate. So dili man kinahanglan man jud og energy atong lawas, dili man nato metabolize atong carbohydrate, mo na mo use na lang ta sa fats. Okay, asa man ni makit-an ang inability to metabolize carbohydrate? Okay, as occurs in diabetes mellitus. Okay, increased loss of carbohydrate from vomiting and inadequate intake of carbohydrate associated with starvation and malabsorption. Mo na nga, if kanang gutom na gani kayo, nag-fasting mo, or kanang wala mo'y kaon-kaon, ginhawa ninyo murag fruity odor, that is an indication nga gi-metabolize na sa imuhang body ang fats, wala na kay carbohydrates. Okay? So, diabetic ketonuria implies presence of ketoacidosis and provide a warning for impending coma in type 1 DM patients. Okay? Ang naay kasagaran taas nga possibility na mag ketonuria or ketoacidosis is your type 1 DM patients. Non-diabetic ketonuria usually seen in children and infants. Okay? Nagka-ketonuria ka pero wala kay diabetes. Okay? Kakaksya or following anesthesia, toxic states, and accompanied by vomiting or diarrhea, or hyperemesis of pregnancy. So also have lactic acidosis. This will coexist with other conditions such as shock, diabetes mellitus, renal failure, liver disease, and response to drugs such as your fenformin and salicylates. Okay? Reagent strip reactions based on sodium nitroprusside reaction. That is your Legal's test for ketones. Okay, Legal's test, sodium nitroprusside reaction. Okay, tanan ba nga katong ketones nato ma-detect aning sodium nitroprusside reaction? No, it does not react with 3-hydroxybutyric acid. Okay? Or beta-hydroxybutyric acid. Okay? Reagent strips without alkali reacts to acetoacetic acid only and not to acetone. Okay? Kung wala gani additional nga glycine, okay, kay acetoacetic acid ra ang ma-detect. Okay? Not acetone. Okay, multisticks detects 5 to 10 mg per dl acetoacetic acid only. Okay? Reagent sodium nitroprusside and buffer. Okay? So, acetoacetic acid, present ganin na siya sa urine, plus na sodium nitroprusside, it will produce a pink or color change ang inyong pads into pink or maroon. Pink to maroon. Chemstrip detects about 10 mg per dl of acetoacetic acid and 70 mg per dl of acetone. Reagent sodium nitroprusside plus glycine and disodium phosphate and lactose. Okay? Acetoacetic acid and acetone plus sodium nitroprusside plus glycine will turn into purple color. Okay? So, unsay makapadetect sa inyuhang acetone? It's your glycine. Addition of glycine. Sources of error: false positive, phthalate dyes, phenyl-sulfathalate or bromsulfathalate, highly pigmented urine. We also have levodopa, your phenylketones, 8-hydroxyquinolone, which is a preservative. We also have acetylcysteine, medications with free sulfhydryl groups such as your captopril. Okay, false negative, improperly preserved specimens, loss of reagent activity. Okay. Nitroprusside tablet test does not react still with 3-hydroxybutyrate acid. Okay. ACE test detects 5 to 10 mg per dl of acetoacetic acid and 20 to 25 mg per dl of acetone. Reagents: sodium nitroprusside, glycine, disodium phosphate, and lactose. Okay, lactose, it is used for better color differentiation. Okay, advantage over reagent strip. It can be used to assay whole blood, plasma, and urine. So inyong ACE test, kay dili lang urine iya pwede nga gamiton nga sample, but also your whole blood and plasma. Mo na iyang advantage. Okay? So inyong i-take note ani sa different diagnostic methods kay ang reagents. Okay? And its sensitivity. So mula na inyong ipang take note. Okay? Nitroprusides tablet test, false positive, large amount of phenylketones, levodopa, and phthalate dyes. Tube test, other test, Rotheras test, modified sodium nitroprusside, and it detects acetoacetic acid and acetone. Mayngan kag Rotheras, unsa nga ketone siya ma-detect acetoacetic acid and acetone. You also have Gerhardt's test, detects acetoacetic acid only. Okay? Unsaon ni siya? Acetoacetic acid plus ferric chloride will turn into red color. Okay? Dili ni siya reagent strip ha. This is a tube test. Okay? And we also have Hart's test, detects beta-hydroxybutyric acid. Okay? Beta-hydroxybutyric acid. Si beta-hydroxybutyric acid, again, dili na siya ma-detect sa inyuhang reagent strip only by your Hart's test. Okay, test. Okay, so for your acetone, pwede siya ma-detect using your reagent strip, but of course, with the addition of your glycine. Okay, also ACE test and Rotheras test. Sa inyong acetoacetic acid, you have reagent strip, your ACE test, and Rotheras test. And para iyahalan jud si Gerhardt's test. Si beta-hydroxybutyric acid, Hart's test only. Okay? Now, let's have blood, hemoglobin, hemosiderin, and myoglobin. Okay, blood, hemoglobin, hemosiderin, and myoglobin. Blood may be present in the urine either in the form of intact red blood cells, that what we call hematuria, or as a product of red blood cell destruction, such as your hemoglobin or hemoglobinuria. Okay? Because any amount of blood greater than 5 cells per microliter of urine is considered clinically significant, visual examination cannot be relied upon to detect the presence of blood. Kaya kanang 5 ka buok, more than 5, dili pa kay na siya makat-affect sa macroscopic nga examination sa ato ang urine. No? Microscopic examination of the urine sediment shows intact red blood cells but free hemoglobin produced by either hemolytic disorders or lysis of red blood cells is not detected. Therefore, chemical tests for hemoglobin provide the most accurate means for determining the presence of blood. Okay, so hematuria, presence of intact red blood cells in the urine. What are the causes? Renal calculi or stones. So, because of the presence of stones in your kidneys, no? So, pwede na masama dito, and that is why it will cause bleeding. Okay? So, renal calculi or stones or lithiasis, it is accompanied with bleeding. Okay? Glomerulonephritis, pyelonephritis, tumors, trauma, exposure to toxic chemicals or drug. Okay? For non-pathologic causes, strenuous exercise, or during menstruation. Naguba jud ang ako ang PPT. No, so sige lang. Okay. Hemoglobinuria, presence of product of red blood cell destruction. Okay. Hemoglobin in the urine. Okay. Causes, transfusion reaction. Okay. Transfusion reaction, malays ang dili compatible ang ato ang blood. Okay. So, muna malays ang ato ang blood. So, there is increased hemoglobin or hemolytic anemias, severe burns, and infections. We also have strenuous exercise, red blood cell trauma. Okay, hemosideриnuria, presence of hemosiderin in urine. What are the different causes? Usually 3 days following an acute hemolytic episode. Okay, free hemoglobin, ferritin plus hemosiderin. So, na free ang or na hemoglobin. Also have hemochromatosis. Okay? Next, we have myoglobinuria, presence of myoglobin or heme-containing protein in muscle tissue nga maabot sa urine. Associated with muscle destruction. Okay? Muscle trauma, prolonged coma, convulsions, extensive exertion, alcoholism or overdose, drug abuse, and muscle wasting. So din ha makakita na taog myoglobinuria. There is already myoglobinuria. Okay, myoglobin in the urine. Okay, diagnostic method, reagent strip method for heme compounds, hemoglobin, and intact red cell and myoglobin. Principle based on the peroxidase-like activity of heme from free hemoglobin, lysed RBC or myoglobin. Okay? Erythrocytes, okay, kung intact ganin na RBC, erythrocytes are lysed by the reagent strip releasing hemoglobin. Okay? So, muna nga, if hemoglobin gani ang present, uniform ang color. But if erythrocyte gani or intact RBC, ang pattern is speckled. Okay? Reagents, hydrogen peroxide and tetramethylbenzidine as its chromogen. Okay? Chemstrip and multisticks detect 0.05 to 0.3 milligram hemoglobin. So, hydrogen peroxide plus the chromogen, which is the tetramethylbenzidine, the reaction proceeds as oxidized chromogen, and in the presence of heme peroxidase, okay, our enzyme heme peroxidase, it will produce an oxidized chromogen and water. Okay? So, results, spotted pattern or speckled pattern indicates intact red cells. Uniform pattern indicates free hemoglobin. Okay? False positive, oxidizing agents such as your peroxide and hypochlorite. False negative, ascorbic acid, formaldehyde, reduced sensitivity, such as with very high specific gravity and high nitrite concentration. Okay? Ammonium sulfate precipitation. Principle, hemoglobin precipitates at 80% saturation with ammonium sulfate. Myoglobin does after 100% saturation. Okay? So, 5 ml urine plus 2.8 grams of ammonia. Okay? I have already discussed about ammonium sulfate precipitation in our previous na topic, which is gross or physical examination of urine. So, I'll not, dinan ako siya balikon din eh. Diba, unsa to'y color sa precipitate, okay, or unsay color sa solution if hemoglobin or myoglobin ang present. So, na-discuss na to nako. Okay, sources of error. This method would give false negative results for urine samples containing less than 300 mg per liter of hemoglobin. Okay, diagnostic methods. We have quantitative tests for myoglobin. Okay, radioimmunoassay, too laborious, time-consuming. Okay, high-performance liquid chromatography. We also have electrophoresis. We also have Rapitex latex agglutination. This is semi-quantitative. And we also have immunoassay. Okay, Prussian blue reaction. This is used to demonstrate iron present in hemosiderin. Okay, uses potassium ferrocyanide solution. And if positive, hemosiderin appears as blue granules singly or in groups. Okay, in renal tubular epithelial cells, as amorphous sediment or as blue granules in cast. Okay, so algorithm, kita gani kag red urine. Okay, so kung lang gihapon ni mo na ni ang sa katong previous na to nga topic. Okay, dipstick, positive, negative. Okay, pag positive, proceed with microscopic examination. Pag negative, other cause na siya. Okay, again. So, kung positive sa dipstick, meaning naagi blood. Okay, let's proceed with microscopic examination. During our microscopic examination, daghan ganig RBC, tan-aw na to ang iyang morphology. Kung dysmorphic gani, there is glomerular hematuria. Isomorphic or normal nga morphology sa inyuhang RBCs, non-glomerular hematuria. Okay? Asa ninyo i-associate inyong dysmorphic RBCs? Glomerular hematuria. Okay, kana kung many RBC under the microscope. But if there is no or few RBC, pero nag-positive man siya sa dipstick, so we'll proceed with ammonium sulfate test. Okay? Clear gani ang supernatant, that is hemoglobinuria. Brown gani ang supernatant, myoglobinuria. Okay? So next, we have bilirubin and urobilinogen. Okay, bilirubin, it is a degradation product of hemoglobin. In normal conditions, excreted in the feces in the form of urobilin. Okay? Adult urine contains only 0.02 mg per dl of bilirubin. Okay, clinical significance appear in urine when the normal degradation cycle is disrupted by obstruction of the bile or when the integrity of the liver is damaged. So usually, pag makakita kag bilirubin sa imuhang urine, it is associated with liver diseases. Okay? Hepatitis, cirrhosis, or biliary obstruction. Okay? Other liver disorders and hepatotoxic drugs or toxins. Okay? Diagnostic methods. For our reagent strip, the principle is based on diazo reaction. Okay, bilirubin glucuronide plus diazonium salt. Okay, it will produce azodi. Okay, bilirubin glucuronide is conjugated bilirubin or direct bilirubin. Okay, and it will produce a tan or pink to violet nga color sa inyuhang reagent pad. Okay, comparison between your multi-sticks and chem strip. You have 2,4 for the reagent. For multi-6, you have 2,4-dichloroaniline diazonium salt. For your chem strip, you have 2,6-dichlorobenzene diazonium tetrafluoroborate. Sorry guys, wala na mao. Okay, sensitivity 0.4 to 0.8 mg per dl, and for your chem strip is 0.5 mg per dl. Okay, so interferences, false positive, highly pigmented urine. Okay, this will interfere with the color sa inyong reagent pad. Drug metabolites, phenazopyridine, rifampin, chlorpromazine. Okay, also indican. Okay, and metabolites of iodine. False negative, specimen exposure to light. Muna akong gingon nga kinahanglan nga nakaprotect from light ang inyuhang samples. Okay, ascorbic acid more than 25 mg per dl. And high concentration of nitrite. Okay, diazo tablet or MAT method, confirmatory test ni siya. Sensitive to 0.05 to 0.10 mg per dl of bilirubin. Icto test, okay, asbestocellulose, and reagents is p-nitrobenzene diazonium, p-toluene sulfonate sulfosalicylic acid, sodium carbonate, and boric acid. Source of error, same as reagent strip. Okay, may kag icto test, that is for bilirubin. Okay, so for your icto test, okay, mag-place kag 10 drops of urine onto 1 square of the absorbent test mat. Mo nang gitawag siya MAT method. Okay, using forceps, remove 1 ecto test reagent tablet, and then recap the bottle promptly and place the tablet in the center of the moistened area. Okay, katong gidrapan nimo og urine. And then you place 1 drop of water onto the tablet and wait 5 seconds. And then place a second drop of water onto the tablet so that the water runs off the tablet onto the mat. And then observe the color of the mat around the tablet at the end of 60 seconds. The presence of a blue to purple color in the mat indicates the bilirubin that bilirubin is present. A slight pink or red color should be ignored. Unsa lang dapat ang color nga naa? Blue to purple. Okay, a slight pink or red color should be ignored. Okay, you can report it as positive or negative. Pero unsa ra ganito? Blue to purple. Pink gani or red color, disregard or ignore na nimo siya. Okay, Fauché test. Principal ability of ferric chloride dissolved in trichloroacetic acid to oxidize bilirubin to biliverdin, producing a green color. So source of error, false positive, aspirin metabolites, urobilin or indicant or urobilinogen. Okay? False negative, oxidation of bilirubin if examination is delayed. Okay, other tests for bilirubin, you have Smith's or iodine test. Positive is emerald green color. You also have Gemelins, concentrated nitric acid. Okay, concentrated nitric acid plus play of colors, green, blue, yellow. Positive sa imuhang Gemelins kay a play of colors, green, blue, yellow, and red. Very colorful si Gemelin. Okay, you also have Otsman test, potassium hydroxide and hydrochloric acid. Positive is green color. Foam test, yellow foam when shaken. Icto test, bluish purple in color. Hoppert's test, mild of lime, hydrochloric acid, and ethyl. Harrison's spot test, barium chloride, Fauché's reagent. Positive, biliverdin kung green. Positive si biliverdin kung green ang naa. Kung coletilin ang naa, yellow. Okay? And also, bilicyanine kung blue. Okay? So, for urobilinogen, normal urine output in adult is 0.5 to 2.5 milligram or units. Okay? Or like units per 24 hours. Okay? Clinical significance occur whenever the liver is unable to efficiently remove the reabsorbed urobilinogen from the portal circulation and more urobilinogen than normal is routed to the kidneys. Okay? So, hepatocellular damage such as viral hepatitis, drug toxicity, toxic substances, and cirrhosis. Also have hemolytic disorders. Kaya in hemolytic disorders, malays ang inyuhang RBCs. And then, hemoglobin degradation product mo increase po. So, there is increased urobilinogen. Okay? So, reagent strip based on diazo or Ehrlich's reaction. Okay? If based on Ehrlich's reaction, that is for your multi-sticks. Okay? Urobilinogen utilizes Ehrlich's reagent, p-dimethylaminobenzyaldehyde, in acid medium producing colors ranging from tan to orange. Naguba jud akong pipiti. Bati kayo. Okay? Urobilinogen plus p-diethylaminobenzyaldehyde in the presence of acid will produce a red color. Okay? Ang imuhang chemstrip kay based on diazo reaction. Okay? Urobilinogen plus diazonium salt, red azo dye. Okay? So, same sila nga red. Pero si multi-sticks based on Ehrlich's. Ang imuhang chemstrip kay based on diazo reaction. Same sila red. Okay? So, sources of error, false positive, sa imuhang multi-sticks, porphobilinogen, 5-hydroxy indole acetic acid, sulfonamides, para-aminosalicylic acid, and you have procaine, you have indican, phenothiazines, methyl dopa, and chlorpromazine. Okay? False negative, old specimens, and preservation in formalin. False positive for your azo dye reaction or azo dye reaction, red urine from any cause. Unsa man to example sa red urine, you have your rifampin. Okay? Unsa to rifampicin. Okay? False negative, old specimen, preservation in formalin, increased amount of nitrite. Okay? Remarks for your multi-sticks, unreliable if urine bilirubin is high. Sensitivity for your multi-sticks is 1.3 milligram per DL. Your chem strip is specific for urobilinogen. So, kung papilion ka, si chem strip na lang imuha kay specific siya for urobilinogen. Ang imuhang multi-stick, it is affected by increased amount of bilirubin. And sensitivity sa imuhang chem strip, very sensitive, 0.4 milligram per DL. Okay, you have tube test based on Ehrlich's reaction. Source of error, same as with the reagent strip test. So this is a semi-quantitative method. Test serial dilutions of urine. Observe for the presence of pink color enhanced by sodium acetate. May surya nagitag Ehrlich, mga red na siya ang color. Results are reported in Ehrlich unit. Okay, ang Ehrlich unit is equal to 1 milligram per ml of urobilinogen. Okay, normal values. Males, 0.3 to 2.1 Ehrlich units. Females, 0.1 to 1.1 Ehrlich units. Recommended specimen collection after the noon meal to 2 to 4 p.m. This corresponds to the time of greatest urobilinogen excretion. So, kanus ang ideal or recommended nga specimen collection after the noon meal. Mga alas 2 hangtod sa alas 4 sa hapon. Kahit dinhi ang greatest urobilinogen excretion. Okay? Now, we have Watson-Schwartz differentiation test. This differentiates between urobilinogen and porphobilinogen and other Ehrlich reactive substances. Now, you have two tubes. One containing chloroform and the other one containing butanol. Okay? So, for example, diba, ato man i-differentiate kung urobilinogen ba na or porphobilinogen ba na or Ehrlich reactive substances ba na siya. So, we have two tubes again. We have chloroform and we have one with butanol. So, sa inyuhang tube nga na ay chloroform, si chloroform na siya sa bottom. Okay? Ang anyuha pod nasa bottom si chloroform, na on top si urine. Sa inyuhang butanol pod nga tube, kay si butanol na asa top layer and nasa bottom layer si urine. Okay, ang pattern niya is ukbo. 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 Uk. Sa inyong chloroform, urine on top, chloroform below. Bu, butanol on top, urine below. Okay? Sa inyuhang urobilinogen, okay, your urobilinogen, it is both soluble in chloroform and butanol. Meaning, pag makakita gani ka nga sa bottom, okay, sa tube nga na ay chloroform, red gani ang bottom. Nya, ang sa inyuhang butanol pod nga tube with the butanol, red pod gani ang taas, meaning ni red si butanol, ni red pod si chloroform, that is your urobilinogen. Okay? Red means soluble. Okay? Soluble si urobilinogen both in your chloroform and in your butanol. Okay? Muna red ang bottom, red pod ang top sa ukbo. Okay? Both your chloroform or soluble in both chloroform and butanol ang imuhang urobilinogen. Okay? Sa imong porphobilinogen, okay, insoluble in chloroform and butanol. So, therefore, dili mo red si chloroform o si butanol. Ang mo red is inyuhang urine. Okay? Red ang naa sa urine. Okay? Wala ni chloroform o ni butanol. Ang sa inyuha pod nga Ehrlich reactive substances soluble in butanol but not in chloroform. Okay? Sumo na siya ato ang nga pag-differentiate sa tulo. Urobilinogen, porphobilinogen, and Ehrlich reactive substances. Okay, dara. Muna ni ang ako nga giingon ganina. Chloroform extraction and butanol extraction. In urobilinogen, urine top layer is colorless. Chloroform is red. Other Ehrlich substances, red ang top layer, and then colorless bottom layer. For porphobilinogen, red urine layer, colorless ang chloroform layer. Butanol extraction, red, colorless. Okay? Ang Ehrlich substances, red and then colorless. And then porphobilinogen, colorless and then red. Okay, urobilinogen is soluble in both chloroform and butanol. Porphobilinogen is insoluble in both chloroform and butanol. Okay, screening test for porphobilinogen, it's called Hosch screening test. Okay, this is for rapid screening and monitoring of urine porphobilinogen. It detects approximately 2 mg per dl of porphobilinogen. Principle is based on Ehrlich reaction with addition of an acid that inhibits urobilinogen. So dili na to kay para manini porphobilinogen nga test, 'di ba? Screening test for porphobilinogen. So mag-add og acid that will inhibit the urobilinogen para dili siya mo interfere sa reaction. Kay both man ang inyuhang porphobilinogen ug ang urobilinogen will react with Ehrlich reaction. Okay? Procedure, 2 drops of urine plus Hosch reagent, that is Ehrlich reagent dissolved in 6M hydrochloric acid. Okay, acid para asa gani inhibit urobilinogen. Okay, observe the top of the solution for the appearance of red color. If naa gani red color, then that is porphobilinogen. You also have shaking solution, red solution seen all throughout. Okay, source of error, false positive reaction, methyl dopa, indican, and highly pigmented specimens. Okay, test for urobilin. Okay, we have Schlesinger's test using Lugol's iodine and zinc acetate, and the positive result is greenish fluorescence. We also have Schmidt's test, 10% mercury chloride, okay, and the positive result is green color. Okay, test for indican. Obermeyer test, reagent is hydrochloric acid, ferric chloride, and chloroform, indigo blue. Okay? Sa inyong Schmidt's test, HCl, chloroform, calcium, and hypochlorite, blue color. Joul's test, lead acetate, thymol, chloroform, Obermeyer's reagent. And the positive result is violet color. So, different findings in urine in different disease process. So, hepatic disease, urine bilirubin, negative. Okay? And then, urine urobilinogen, positive. Liver damage, urine bilirubin, positive or negative. Urine urobilinogen, positive. Bile duct obstruction, triple positive sa inyong urine bilirubin, and urine urobilinogen is normal. Okay, let's proceed with nitrite. So the reagent strip test for nitrite provides a rapid screening test for the presence of urinary tract infection. The test is designed to detect cases in which the need for culture may not be apparent. But it does not intend to replace the urine culture as the primary test for diagnosing and monitoring bacterial infection. Okay? So, unsa siya? Mara siya mahulog nga screening test for or indirect test for urinary tract infection. Okay, but dili tanan nga urinary tract infection kay pwede na to ma-detect using our nitrite. Okay, kay not all bacteria or organism kay naa sila'y reductase. Okay, reductase are the ones that reduces nitrate to nitrite. Okay, clinical significance, cystitis, pyelonephritis. Okay, cystitis is lower UTI. Pyelonephritis kani kay kung wala na agapan imuhang cystitis, then proceed sa upper nga part sa imuhang upper na siya nga part sa UTI. Okay? Upper urinary tract infection, si pyelonephritis. So kinani sa imuhang nga case study, di ba? Uncomplicated cystitis. Okay, evaluation of antibiotic therapy, monitoring patients at high risk for urinary tract infection, screening for urine culture specimens. Okay, based on the ability, ang inyong reagent strip, based on the ability of certain bacteria to reduce nitrate to nitrite. Okay? Certain bacteria lang, dili tanan. So, dili tanan UTI kay pwede nga ma-detect using your nitrite. Okay? Nitrite is detected by grease reaction. Nitrite at an acidic pH reacts with an aromatic amine or amine, para-arsenic acid or sulfanilamide to form diazonium compound that reacts with tetrahydrobenzoquinolene to form azodie. Okay, so nitrate in the presence of bacteria that has reductase, and it will be reduced to nitrite. To nitrate to nitrite in the presence of bacteria with reductase. Okay? So, kanipod, ang pag-convert from nitrate to nitrite, dili na siya naaga ni bacteria. No, kay muna ang ideal specimen for your nitrite is first morning or at least 4 hours contact sa inyuhang bladder. Okay? 4 hours. Okay? Your bacteria needs time to convert nitrate to nitrite. Okay? Nitrate plus aromatic amine in acid pH will produce a diazonium compound. And then this diazonium compound plus 3-hydroxyl 1,2,3,4 will produce pink 1,2,3,4 tetrahydrobenzoquinolene. Okay? Quinolene. Basta mag-ingon kag quinolene, that is your for nitrite. And then they will produce pink azodie. Okay, so inyuhang multi-6, ang reagents P arsenic acid tetrahydrobenzo H-quinolene 3-ol. So yung chemstrip, sulfanilamide 3-hydroxyl 1,2,3,4 tetrahydro 7,8-benzoquinolene. Okay, sensitivity. For your multi-6, you have 0.06 to 0.1 mg per dl nitrite ion. And your chemstrip, 0.05 mg per dl nitrite ion. Okay, source of errors, false negative, non-reductase containing bacteria, of course. No, kinsa may mo reduce anang inyuhang nitrite inyuhang nitrate kung wala siya reductase. Insufficient contact time between bacteria and urinary nitrate. Mo ni ako ang gingon nga should be performed on first morning specimen or katong 4-hour specimen. Lack of urinary nitrate in patients with green vegetable diet. So, unsa man po i-convert into nitrite kung walay nitrate, diba? Large bacteria that converts nitrite to no detectable nitrogen product. So, if daghan kayo, heavy kayo ang bacteriuria, no? Daghan kayo ang mo convert, na sobraan og convert, no? Instead nga nitrite lang, naabot na siya og nitrogen. So, unsaon pa man na pag-detect nga nitrite man ang ma-detect sa ato ang reagent strip. And also the presence of antibiotics. So, kung nag-treatment ka, of course, mugamay man ang imuhang, matay man ang imuhang bacteria. Also, high ascorbic acid concentration and high specific gravity. False positive, improperly preserved urine, and also high pigmented specimen. Correlations, protein, leukocyte, and microscopic. So, di lang kami ngon diretso nga, positive sa nitrite. Kay bahalag positive sa nitrite niya, wala kay nakita nga bacteria. Unsaon man na nimo, mingon jud ka nga na UTI bisag walay bacteria. Okay? Mo na ako ingon nga dapat mo correlate siya. Okay, leukocyte pod kay, 'di ba? Your leukocyte will increase in the presence of bacterial infection, especially your neutrophils. Okay? So now, leukocyte, clinical significance, urinary tract infection. There is no true infection kung wala ang leukocyte, wala pod ang bacteria. Okay? Urinary tract infection, inflammation of the urinary tract, screening for urine culture specimen based on the presence of leukocyte esterase. Okay? Extracts of human neutrophil azurophilic granules. Your leukocyte esterase, kayon sa na siya? Azurophilic granules from your leukocyte. So, muna ito ang i-detect. Okay? Reagent strip reaction based on the action of leukocyte esterase to catalyze the hydrolysis of an acid ester to produce aromatic compounds and acid. So, nata endoxyl carbonic acid ester in the presence of leukocyte esterase, which is produced again by your granulocytic leukocytes. If walay granules ang inyuhang leukocyte, and then, so, unsa man na, wala tay leukocyte esterase. Okay? Okay, it will turn into endoxyl and acid endoxyl. So, endoxyl plus diazonium salt will produce a purple azo dye or azo dye. So, comparison of your multi-sticks and chemstrip reagents. For your multi-strips, derivative pyrrole amino acid ester and diazonium salt. Your chemstrip is endoxyl carbonic acid ester and diazonium salt. Sensitivity for your multi-sticks is 5 to 15 WBC per high power field. Your chemstrip is 10 to 25 WBC per high power field. So, your multi-sticks is more sensitive than your chemstrip. Kaya bisag 5 ra kabuk, ma-detect niya. Source of error, false positive for strong oxidizing agents. Also have formalin and highly pigmented urine. Okay, false negative if high levels of protein, glucose, oxalic acid, ascorbic acid, and nitrofurantoid, gentamicin, cephalosporin, and tetracyclines. Of course, antibiotics. Correlations, protein, nitrite, and microscopic. Okay, do not contain leukocyte esterase in yung lymphocyte. Of course, your lymphocyte is a granulocyte. Wala siya leukocyte esterase. Kaya wala man siya granules. Okay, also with your erythrocytes, bacteria, and renal tissues. But there are, for example, your trichomonas, dili siya leukocyte pero na siya leukocyte esterase. Okay, your trichomonas and your histiocytes. UTI caused by bacterial infection, positive for nitrite and leukocyte test. Okay? And also, dapat makakita sa jud ka og bacteria, ha, under the microscope.